Good evening. Good evening. Thank you, all of you, for coming here in Saturday night. And as usual, we are starting 30 minutes late. That is the Indian Standard Time. Okay. So, where is my PPT? It is not reflecting there. Okay. So, I welcome you all on behalf of Gujarat Hospital. The theme of this conference is little bit different. Okay. So usually what happens in this conference, we are going to demonstrate 20 to 25 live cases depending upon the time permitted tomorrow, and we are going to introduce 5 new technology live demonstration in South Gujarat tomorrow. So a few of them are highlighted. One is first is the speedboat. Speedboat is a device. It's a generator that is a different from the routine electrocautery, and it depends on the tissue impedance. So you need not need to adjust the cautery setting for the cutting or coagulation. So right now it has been developed for the gastroenterologist, but I think within a 6 month or a year, surgeons are going to use it, and they are very what we call innovating, because I have personally attended meeting of there, and one of the guy from Singapore is coming, Mr. Ken. So if you want to discuss something about the generator, he is the best guy to discuss. In that we can coagulate, we can cut everything with a single device. We can inject everything. There is no need of exchange of device, and it acts on the impedance of that is the beauty of that device. And I think that is the another what we call the platform that may change the concept of the generator platform in surgery or in gastroenterology. Second is the revised ESG. Revised ESG is a surgery. Endoscopic sleeve gastroplasty is now very well established, safe, and durable technique that has been established. Okay. So second is the revised endoscopic sleeve gastroplasty, in which a patient who underwent the sleeve gastrectomy or a gastric bypass with the large outlet, what you can do, you can simply do 2 or 3 stitching endoscopically, and again make his stomach slow or outlet small. So patient again started losing weight. Okay, so it's a daycare procedure, hardly 30-minute procedure, and patient can go home on the same day within 4 to 5 hours. So that we are going to demonstrate first time in South Gujarat tomorrow around 9:30. Before that, we are going to demonstrate routine endoscopic sleeve gastroplasty that we have demonstrated in 2018, and at that time Dr. Mohit Bhandari were at the Gujarat hospital, and after that we have performed many endoscopic sleeve gastroplasty with very good result. The third we are going to demonstrate is a artificial intelligence called the GI Genius. Now in GI Genius, artificial intelligence automatically detect the polyp formation inside the colon. Okay, so what happens, the large polyp we can easily see, but when the polyp is small, less than 5 millimeter, we can miss it with the naked eye. So that device, artificial intelligence, indicates that here is the small polyp and it looks like a adenoma and you have to remove it. So it has a great advantage, particularly for the screening procedure and the person with the family history of the colon cancer. Okay, so this is the fourth, we are going to demonstrate the spiral enteroscopy. Dr. Rajput sir is here, Sanjay Rajput sir from Ahmedabad. Everybody knows him, and one of his colleague, Dr. Radhika Chauhan, will be there. to teach us a spiral enteroscopy, and he's the first one in Gujarat who have a spiral enteroscopy, and used to do it at least 2 or 3 procedure per what we call a week. And I personally feel this is the best device right now which is clinically used, because small bowel is very well uh, underutilized or undervisualized part of intestine because of the lack of the proper modality, and that obstruction is definitely overcome by this spiral enteroscopy. So we have 4 cases of spiral enteroscopy tomorrow, depending upon the time permits. But Dr. Radhika will be there to teach us how we can do a spiral enteroscopy, and even you can do therapeutic like small bowel polypectomy. You can do a small bowel biopsy. Okay, and last we have a magnification endoscopy, in which that is you can zoom the particular area, and then you can put an NBI to see whether this is a malignant potentiality of the malignant. Okay, according to the NICE classification. So these are the 4 5 things we want to demonstrate first time, and I hope it will be good. So this conference is all about something to do new thing. Okay, so even in this conference, why we should organize the medical physical conference? Okay, there are plenty of the YouTube webinars, you can always learn from there. So if you see the paper in 2000, I think it is in the 2015 paper, there are they have seen the data of major conferences in the India. Okay, and they see there are 53 major conference, means conference which has more than 300 delegates. So that calls as a major conference, and 150 minor conference, like delegate around 50, 80, 100 like us. Okay, so why to use so much of manpower? Why to use so much of finances if you can learn online? And what is the observation? The people coming again and again. Okay, few people are used to attend each and every conference, and the young guns are missing. Those who are in the learning phase are missing. So if we see, why should we attend the medical conferences? It is to meet the old friends, and it is for the professional networking, to project self. Sometimes we can project ourselves, okay, I have this skill. Okay, then to spend quality time with the family entertainment. But does this purpose really served? If you go outside Surat with your family, do you really think you are able to do means you are able to learn something seriously? I personally I am not able, not able to do, but few people are able to do. Then to maintain a relationship, sometimes for the just formality, because we have a very good relation, okay, person comes. Okay, then to update a recent advances and develop a new skill and gain deeper knowledge. I have put it last, but it is not a last. Okay, it should be first. But these are the priorities. So why do we organize conference? Okay, to promote education, it's a self-running process for organizer. For organizing such a live event, I have to call at least 1,000 people. Okay, so it gives me a good management skill. I need a blessing of the seniors. Okay, so I must say UNS Clinic and the NIG has helped me a lot for tomorrow's setup. To promote a skill development, suppose spiral enteroscopy is coming tomorrow. Okay, so few of our team member are going to learn the spiral enteroscopy. So in future, within 6 months, 8 months, if everything goes well, we are equipped with the spiral enteroscopy, and to project certain things. And it is an indirect serving of society. The next lecture will be of Dr. Amit Mathew. If you remember, the endocrill has been introduced by Dr. Amit Mathew. The glue we are using right now, that has been introduced in India by Dr. Amit Mathew. So that is by learning, by research. He has collaborated with the scientists and then developed a low cost glue in India, and you see the impact. Okay, I personally feel at least in India every day 3,000 cirrhotic must underwent this procedure, and it able to helps the society by preventing further damage. But when you go for the physical conference, suppose you see the same event, I have even also advised the registration link. But if you are in your office or clinic, you are not going to attend. So you have to break your routine. You have to come here and you have to focus. That is necessity to learn anything. And those who come here, it indicates that they have something burning or some desire to learn. So they are able to sacrifice their practice and come. Okay. So that meet professional idol face to face. This is another motive to organize conference. Okay. I have been trained by Dr. Sainani for manometry, Dr. Rajput sir for many endoscopic procedure. Dr. Kalpit is there. He is from USA, otherwise from Surat, and doing excellent endoscopic sleeve gastroplasty there. Dr. Zahir Nabi from Asian Institute of Gastroenterology is there. Okay, so I just see them and I inspire myself. Okay, these are my seniors, these are my teachers, and if they can do, I can do, and I can learn, and I can go to him at any point of time if I am stuck up. So you meet your professional idol. Suppose you are surgeons and you are junior surgeons, and some of your very good senior surgeons are here. You just interact with him for 5 minutes and you will get a plenty of the inspiration. So these are the another point. And there is no substitution for meeting someone in real life. Distance relationship doesn't last long. Okay, so how to improve our self, change our mindset. When we come to any conference, it is better to change our mindset. That first mindset, we are going, we are listening. You come here, you sacrifice your practice, you are going to sit here for 2 days. Okay, so there are plenty of the time and social life has been sacrificed, so you have to utilize that time. Okay, so this is our first mindset. Okay, if I am going to conference, I will definitely learn something new. There must be a specific CME and focus CME. So that's why in July we have particularly focused on the cirrhotic. Now we are particularly focused on the endoscopy procedure. Educate the resident doctor, and that's I am usually failed, because each time I am trying to get some resident doctor, at least they come. Okay, but I personally feel it is very difficult to get them. Organizer must have some specific vision. So that's for me and our team. Healthy and transparent partnership. Okay, so I thank all the sponsors, okay, who have partnered in the not only financially but extremely helpful as a manpower. As an individual, it is very difficult. Or as a me, Naresh Bhai, Ram sir or Tejas sir, 4 people can't organize this conference. Require plenty of the manpower. And in this conference, we are going to award the formalities. So what are the formalities? When patient chairperson comes or faculties come, what we do? We give flower, we give memento, and the precious time you are coming here, at least 20% of the time are wasted in this formality. So the chairperson, I heartily thank chairperson for chairing that session. Okay, but we are not going to perform this formality for 2 days. For faculties, this time memento is something different. It will be something specific from Surat and particular item for food. Nothing like a sealed, because I know these faculties are used to get a memento twice a week. They used to take a lecture twice a week somewhere. Okay, and we are increasing the number of the chairperson to increase interaction. What happens? Sometimes the people in the last row used to sit there. Okay, they want to ask something, but they are not able to ask something. So I increase the number of the chairperson for 2 days. So each one comes forward. You are not a separate. Chairperson are not separate here. You are amongst, but you are on the front row. So you can ask and you can feel that you are, you can ask anything. Don't hesitate. Huh? This is a family. Okay. So this time, this is the difference. No flower, no felicitation, no introduction for me. Try to keep discussion academics. That is very, very useful when I see the endoscopic procedures. When I used to demonstrate the endoscopic procedure, one question coming is, what is the cost of this procedure? Up to that, it is okay. Second question is coming, our patient is not able to afford, this is very costly. Now you, working environment of you and these faculties is different. Okay, patient class of each and every individual is different. the people or procedure which is not affording for your class of patient may be affording from other surgeon. So affordability is different issue, but you should be focused on the why this has been done, how this has been done, and what is the what we call the maximum utility for the patient. Okay, and I thanks Dr. Arora sir and entire Surgeon Society of Surat for wholeheartedly support me. I thanks in advance all chairperson, resident doctor, delegates, and entire team of Gujarat Hospital also. So this is a very important. You just ask question, make it interactive. Okay, don't sit idle. Whatever you want to feel, you can ask to the faculties. They are I know all of them very personally. Okay, don't think that what people think of. Okay, it doesn't matter. You come here, at least you gain something and go, then this purpose has been fulfilled. So science is like just Lord Krishna. They are continuously giving us a hint of something, and you should ask question. Okay, even Arjun asked question where problem are there. Okay, so try to become a Arjun with the science. Okay, try to ask the question, try to solve the problem in your clinical practice. And with that, I think Dr. Amit Madhu is coming online because right now he is in Odisha. Okay, so he is going to give his lecture online. I will just formally introduce. First is Dr. Rajesh Sainani sir. He is from Mumbai. Okay, and everybody knows about this. He is a very famous globally for the manometry. Okay, he has a plenty of the research paper regarding the manometry. On the second chair, Dr. Kalpit Devani. He is from Surat and since practicing as a gastroenterologist since last 10 years in the USA, and he has a mastery of the spyglass as well as endoscopic sleeve gastroplasty. After that, Dr. Zahir Nabi is there. He is from Hyderabad, Asian Institute of Gastroenterology, and a very, very good guy and a go-to guy at the time of the problem. And he is excellent in the third space endoscopy. And after that, Dr. Sanjay Rajput, I think that name needs no introduction. Okay, everybody knows him. And you can learn plenty of, he's excellent in everything, and you can learn plenty of the things. You ask the thing and here's the answer. Okay, so Dr. Rakesh is coming. Okay, Dr. Kapil is already there. He is also coming. And here is Dr. Smith. He is in Kiran Hospital right now. He used to work with the Gujarat Hospital. Just before a month, he switched to the Kiran Hospital. And other Dr. Tejas, Dr. Ram, and Dr. Naresh Bhai, everybody knows him. So where is Harshil? Dr. Harshil is there. He is our fellow endoscopist. And another Dr. Praful is there. Where is Praful? Praful is there. He is gastroenterologist with me. Okay. So I think he's talking with Dr. Amit Madhu also. So Dr. Amit sir will come online. Harshil? Amit sir is connected. So he is connected. Okay, so let's start with the legend, Dr. Amit Madhu.
Hello.
Yeah.
This is Dr. Amit Madhu. He doesn't require any introduction, you all know. He is awarded Padma Shri in 2013. So I would like to invite a chairperson to share this session, Dr. Rahul Nayak, Dr. Arora sir, Dr. Jignesh Patel from Ankleshwar, Dr. Ram Rakshpal, Dr. Manish Mehta. Sir, please come forward and occupy the front seats. Dr. Amit Madhu, can you hear me?
Yes, I can hear you.
Sir, the platform is yours, and welcome, sir, and thank you for coming. You can start your lecture because time is precious for you.
Okay, thank you. Well, first of all, I just want to thank everybody for calling me and asking me to talk to you today in your prestigious meeting. And I would like to specifically thank and congratulate Dr. Saumin. Actually, I did not know Dr. Saumin. I had only heard about him, but I did not know him so well until I recently met him at Thailand when we had conducted this speedboat workshop for which Dr. Saumin attended because he wanted to learn this new technology. And that is the time I interacted with Dr. Saumin. And let me tell you that my impression about him after I met Dr. Saumin is I came across a person who was extremely enthusiastic. And I realized that Dr. Saumin, he has got a very progressive and a deep vision for the future. His thoughts were very grounded to the grassroots level. And most importantly, I could realize that he has got a fire inside him. And that fire which I could see in Dr. Saumin is going to take him a very long way to reach very great heights in whatever specialty or whatever field he wants to pursue. And with this introduction, I just want to start my talk on bariatric endoscopy, which Dr. Saumin asked me to give. So let me share my slides with you. So what I want to tell you is bariatric endoscopy, if you were to see it, the situation of obesity in our country, a very recent study published in 2020, a nationwide cross-sectional study, and it will be amazed to see that the overall prevalence of obesity in a country like India is 40.3%, where initially we felt that Indians were malnourished and majority of the people were thin. But look at this, 40.3% overall prevalence of obesity in a population which was more than 1 billion. So just imagine what is the amount of obesity, pandemic or problem which is there, which we are going to face in the future. The second very interesting issue is that obese people in India have got a very peculiar obesity, and that is central obesity. Majority of them have got obesity in the central part of the body, predominantly visceral obesity, which is around and inside various organs. So therefore, these people are affected by obesity related comorbidities quite often. In fact, the World Health Organization has in fact modified the classification of BMI predominantly for Indians and for Asia Pacific region, where they found that even at a low BMI of 23 to 25, these people are at increased risk of comorbidities, 25 to 30, moderate risk, and even low BMI of just above 30, they have a severe risk of comorbidities, various types of comorbidities. And that is exactly the reason why various treatment modalities have evolved for obesity, starting from simple lifestyle management, dietetic changes, till advanced and major surgical procedures. Various types of procedures are there. And of course, surgical procedures give the most robust and the best results for the obese patients as well as for the treatment of type 2 diabetes. But all of us know that more aggressive the procedure is, it can be associated with its risk as compared to very simple things like lifestyle management or other things. Well, surgical procedures have been the mainstay. They have been the gold standard of treating obese patients with excellent long-term results. We have seen so many bariatric surgeons doing various types of procedures. You see here, excellent excess body weight loss of more than 65%, some reaching even almost 80%, with total body weight loss almost 30 to 40%. But in spite of refinement in technique, the best of centers, the best of surgeons, some complications, some adverse events are associated with these bariatric surgical procedures. Of course, if you have problems like a leak, it can become a nightmare, not only for the patient, but even for the treating surgeon. And that is exactly the reason why a very small percentage, probably even less than 1% of obese people agree to undergo a surgical procedure. Well, another interesting paper which was published in 2021 in the International Journal of Obesity, if you were to study the overall comorbidities associated with obesity, and you start calculating how much weight loss is really required to reverse these comorbidities. You see here, out of all complications of obesity, the total body weight loss that is required to reverse the comorbidities is anywhere between 10 to 15%, which is not too much. Now, can this be accomplished by simpler techniques? Yes. It can be accomplished by a middle of the road approach. And that is exactly why bariatric endoscopic procedures now have come to the forefront, and more centers in the world and even in our country have started taking up to bariatric endoscopic procedures. The simplest bariatric endoscopic procedure is, of course, putting a gastric space occupying balloon inside the stomach. And this is a very simple procedure. There are three types of balloons which are presently available in India. First is the Orbera intragastric balloon, where you fill in around 500 cc's of normal saline or even water, in which we mix methylene blue. Or we can put this adjustable balloon, which is a Spatz balloon, which we can increase up to 800, 900 cc's. We can keep for a longer period of almost 9 months or even 1 year. And of course, we have the newly introduced swallowable balloon called Ellipse or the Alluron, where even an endoscopy is not required. This can be done on an OPD procedure. And this balloon is in the form of a capsule to which this catheter is attached. All that the patient has to do is to swallow the capsule. And then the endoscopist fills this balloon with water by attaching this catheter to a saline bag with a compression device. And then after filling in 400-500 cc, you just pull the catheter out, the balloon remains inside. And then 4 months later, this balloon automatically decompresses and passes out in the stools. Appears very simple. Well, these three balloons are presently available in our country, in India for use. The most accepted indication for balloon placement is, of course, primary treatment for class 1, class 2 obesity, low BMI, patients who are not morbidly obese, or it can be used as a preemptive therapy for problems like sleep apnea, hypertension, bridge therapy before bariatric surgery or liver transplant. And of course, more and more patients nowadays are referred to us from the liver department of our hospital for the reversal of NASH. So instead of just giving medical treatment for NASH, they feel that if they lose 10-15% of the total body weight, these patients have shown a very good reversal of their NASH problem. And therefore, this is a very important evolving indication of balloon placement. Of course, there are absolute contraindications like portal hypertension or acute duodenal ulcer, severe gastritis, etc., which of course cannot be seen when you use the swallowable balloon because you're not doing an endoscopy here. So I personally still prefer that we should do an endoscopy before placing any balloon. So I'm not a great proponent of the swallowable balloon presently, at least. Of course, pregnancy and large hiatus hernia continue to remain limitations. What about the data on the weight loss of balloon placement? You see Orbera, Spatz 3, as well as Allurion. The total body weight loss at the end of 1 year is approximately 10 to 12%. Not bad, sufficient enough to reverse some comorbidities, sufficient enough to change cosmetically. Some young girls who want to get married, they want to place a balloon temporarily for a few months. This is a very good indication where without surgery, without doing any major procedure, you just place a balloon, give the patient proper dietary counseling, and then once the patient weight reduces, that patient is happy and everyone is happy. The second commonly done procedure is, of course, a gastric restrictive procedure, which is called as the endoscopic sleeve gastroplasty. Dr. Saumin just told us that they have also started doing it. There are a few centers which are doing it in the country already. And this endoscopic sleeve gastroplasty is basically done on this principle by which we attach a suturing device at the tip of the endoscope. We go inside the stomach, and then from inside the stomach, by using this suturing device, we can do a full thickness plication of the greater curvature of the stomach. What we do here is we have modified the technique over the years since its introduction. We nowadays don't do this marking with argan plasma coagulation, but the technique is that basically we do a full thickness suture starting from the anterior wall, going to the greater curvature, then on the posterior wall, again going in a U-shaped fashion. And we start the suturing just proximal to the incisura angularis, and we end it just distal to the fundus. We leave the fundus intact and we leave the antrum intact. Now with this, what happens is basically we not only reduce the size of the stomach, but we reduce the length of the stomach, and we also reduce the gastric emptying. So the patient does not feel hungry for at least 6 to 7 hours, and therefore they lose weight. Well, again, accepted indication, class 1, class 2 obesity. It can be used for morbidly obese patients who are not willing for surgery, but you want some gain, some reversal of their comorbidities, some improvement in their sleep apnea, some improvement in their joint pains or arthritis. Just motivate them a little bit so that they can start walking, start doing some exercise. You can do the ESG procedure. It can be used for comorbidity reversal like NASH, joint pain, hypertension, dyslipidemia, sleep apnea, etc. And very important evolving indication which is going to be demonstrated in this conference, what Dr. Saumin said, is post-lap sleeve gastrectomy weight regain, which happens because of enlarged the stomach remnant, where instead of subjecting this patient to a Roux-en-Y bypass or a repeat cutting of the stomach, we can go in and take a few sutures, reduce the size of the stomach, and it has a very good result. Absolute contraindication, of course, is portal hypertension with gastropathy, coagulopathy, and relative contraindication is severe gastritis because this can bleed. These are going to be full thickness sutures. Well, the device is a little cumbersome. We have to use the double channel endoscope in our country. In some countries, the single channel device is also launched. But at least in India, we use the double channel endoscope from Olympus or from Fujinon. This is the device which is attached on the tip of this of the endoscope. And this is the handle by which we can close this needle which is coming inside. And there are various other things which are used. This is the needle to which a 2,0 proline is attached. Just to show you how the procedure is performed, of course, it is going to be demonstrated in this conference. If I would have come there, I would have showed you, but this is a video which it depicts how we are going to now do the suturing procedure. First and foremost is to load the needle on this needle driver. This is the needle driver. So I've loaded the needle now from the back, and then we select the area where we are going to take the first suture. You should make sure that you don't go in the antrum. Always remain proximal to the incisor angularis, because if you go in the antrum, because of the very strong contractility and motility of the antrum, the sutures will loosen up very fast and you will not have any effect of the ESG procedure. Well, then we pull the wall of the stomach inside by using this screw type of a device called as the helix. And when the wall comes between the two towers, we close the handle, the needle comes from one side to the other. The needle is again retrieved by using this needle holder. And after retrieving the needle, again we transfer the needle on the needle driver, and then we are ready for the second suture. So the second suture is taken over here, third suture here, and this way we go along the greater curvature of the stomach, right till the posterior wall. And after we have reached the posterior wall, we take a U-turn, and keeping about a gap of 1 to 1.5 centimeters proximally, we take a U and we go back again towards the anterior wall. So this way you can see now how we have taken these continuous sutures. Remember that these are full thickness sutures, that if you pull the suture very hard, it's not going to cut through because these are not mucosal stitches. The suture has gone almost till the muscularis propria, and sometimes it also crosses the serosa. So this way, now you keep on suturing it. You take one U, second U, third U, and fourth U. Sometimes you have to take even 5 U's, by which we are going to completely plicate the greater curvature of the stomach. Now, once we have plicated the greater curvature of the stomach, if you were to see, this is how it looks. It looks as if you have done a laparoscopic sleeve gastrectomy. This is the complete suture line, what you've done. This is the tube. Ahead, if you go, you will have the antrum. And then if you do a imaging study later on, you'll realize that after the ESG procedure, the size of the stomach reduces by almost 40 to 50%, leaving the fundus intact. That acts as a proper accommodating area for the food. So once the patient eats food, because of the reduced gastric emptying, the food goes back, stays in the fundus, and the patient has satiety, does not feel hungry for at least 6 to 7 hours. What is the main advantage of the ESG procedure? It's a gastric restrictive procedure, but maintains the anatomic structure, maintains the innervation, maintains blood supply, potentially reversible. If the patient has a lot of severe pain, retching, vomiting, you can just go inside and cut the sutures. The whole stomach will open up. It is reproducible. It can be easily done again, repeatable if required. In fact, nowadays, all the patients, we tell them that at the end of 7-8 months, we do a repeat endoscopy. And if their weight loss starts plateauing, we can perform a scopy again. If we find some sutures have opened, that we go in and take a few more sutures. It is very safe. In all reported studies, we have done 300 procedures till now. There are no serious adverse events. It's more durable than the balloon. And finally, it can again be upgraded by surgery. What is the data on the endoscopic sleeve gastroplasty? The first single center large cohort study published from Saudi Arabia, 1,000 patients you see here. Total body weight loss at the end of 18 months was almost 15%. Well, a systematic review and meta-analysis published in 2020. Once again, total body weight loss between 12 to 24 months, 2 years follow-up, almost 18%. So quite good, 18% after doing a simple procedure like endoscopic sleeve gastroplasty without cutting the stomach, without doing a bypass. I think this is good enough, not only to reduce the weight, but also to reverse comorbidities. In fact, the same group from Saudi Arabia, in 22, they published this paper, which was a non-inferiority propensity score matched comparative study between ESG and laparoscopic sleeve gastrectomy. And see the interesting data. The interesting conclusion of the end of this comparative study was that total weight loss at the end of 3 years Not too much difference between ESG and LSG, only around 5% difference between the two. And the same is true with reversal of comorbidity. Not too much of difference between the two procedures. So you can achieve a good amount of weight loss by doing this simpler procedure. Very recently, this paper was published by Baram Abu Daye as to how does this procedure actually help. And they studied the effect of ESG on gastric emptying, gastric motility, and the hormones. And they realized that the most important effect was it reduces the gastric emptying. And because it delays the gastric emptying, and this effect persisted for more than 1 year, but it did not have any effect on the gastric hormones or the gastric motility. The motility remained the same, hormones remained the same, but the gastric emptying reduced, because of which these patients don't feel hungry and they reduce weight. And finally, this prospective multi-center randomized trial was again just published a few months back, 1 month back, from United States, 9 United States centers. You see here, total body weight loss with ESG plus lifestyle management was around 14% at the end of 52 weeks, as against lifestyle management alone, which was only 0.8%. And you see here that now after this device got introduced into the US market and it got FDA approved. The second restrictive procedure is called as the POSE-2. This is also a type of a suturing device, but not a suturing device. Actually, it's the plication device, which is called as this device, which is called as the POSE-2 device. And here you can see where transverse and longitudinal plications are done. The champion of this is Gotrand Lopez Nava, who was in fact invited by Dr. Rajput to Ahmedabad a couple of years back. And you see here, he has published this data on 44 patients in a prospective multi-center study of the POSE-2 procedure. POSE-2 means what? Only the technique is different. The device remains the same, where the technique of sutures placement has been changed. That's why it is called POSE-2. And the technical success is very good. And here also, the total body weight loss, you see here, 58% of excess body weight loss and 15% total body weight loss at the end of 2 years by using the POSE-2 device. Then finally, I'm going to tell you about 3 techniques which are now in the process of development endoscopically, which not only affect the weight reduction, but they also have an impact on the reduction of HbA1c, or they can be considered as endoscopic metabolic procedures. Now, the first of these 2 procedures, the first 2 procedures are either to bypass the foregut or to replace the lining of the foregut by these 2 techniques, that the duodenojejunal bypass sleeve, which was called as the endo barrier, and of course the duodenal mucosal resurfacing. Now, the duodenal barrier bypass sleeve, or what we call the duodenojejunal bypass sleeve, is this type of a sleeve which can be placed endoscopically. This portion fits against the pylorus, and this sleeve, which is made up of polyfluoroane, it goes in the proximal jejunum, so that what happens is the nutrients which the patient eats, they bypass the abnormal enteroendocrine cells located in the duodenum. So what is the cause of type 2 diabetes is this portion of the duodenum contains abnormal enteroendocrine cells. So when the nutrients pass, they give wrong signals to the pancreas, and therefore the patient develops insulin resistance. But if these nutrients directly pass into the distal jejunum, then there is early exposure of the nutrients to the small bowel, which stimulates the L cells, leading to secretion of GLP-1 and PYY, and therefore it stimulates insulin secretion and improves the insulin sensitivity. Well, what are the results? Initial pivotal trial from the United States was in fact stopped because after using the endo barrier, they realized that these patients develop complications like liver abscesses, because the place where at the pylorus the device was fit, it caused ulceration, infection, and that led to the liver causing liver abscesses. So therefore, the CE mark of this device was taken off, but this open labeled randomized control trial continued in the UK. And at the end of 2 years, they realized that this device did not show any significant benefit over 2 years, but the adverse events were still concerning. So therefore, this device is presently taken out of the market. It is undergoing some clinical trials, but I personally don't feel that the endo barrier or this sleeve type of device will ever come into clinical use, because it's extremely difficult to fix the device at the pylorus. And this being a very mobile area, it will always cause its complications. The second is, of course, to change the mucosa, which is abnormal, by using this hot water. So for this, this catheter is used, which can be passed over a guide wire. You do an endoscopy, place a guide wire in the jejunum, and over that, this device is passed. And then there is a balloon over here, which is inflated. And by inflating this balloon, inside we can inflate the balloon by putting water which is heated up to 95 degrees, and then the mucosa beyond the ampulla of Vater till the DJ flexure is completely ablated. Now, once you ablate this mucosa, what happens is that within a period of 1 month to 3 months, new mucosa appears with new cells, because of which these cells increase the insulin sensitivity and it improves the glycemic control. What is the data on this device? There are 4 studies which have been conducted till now, a good systematic review and meta-analysis. Totally 127 patients were analyzed. At the end of 6 months, HbA1c dropped by almost 1%. Not very robust. Of course, with surgical procedures like diversion or with RUA bypass, HbA1c reduces considerably more than just 1%. But at 3 months, you see here almost 2% drop of HbA1c. There are presently 3 ongoing trials with this, and they have found that the longer area you ablate, the better are the results for reduction of the HbA1c. And finally, I just want to tell you one final procedure which is likely to come very soon in a few years, which can be done by endoscopist, which is very similar to a surgical bypass procedure, where we can do a partial jejuno-ileal by diversion by using incisionless magnetic anastomosis. Now here what we do is, endoscopically, magnets are placed, hexagonal magnets, which are not initially open like this, but after you release the magnet opens up. So using a colonoscope, we go per orally, go till the proximal jejunum, release one magnet, then we use a colonoscope from below and we release one magnet in the ileum. Once these magnets open, these magnets approximate towards each other. Within a period of 1 week, the area in between the 2 magnets completely necroses off, and excellent anastomosis is formed like this. See, this is the endoscopic picture after an incision-less magnetic anastomosis. Now you see here, it causes a partial jejuno-ileal diversion. Now, from the single arm first in human pilot study, which was published, 10 patients who had type 2 diabetes, pre-diabetes, or no diabetes, where they found that all anastomosis were widely patent at the end of 1 year. Total body weight loss was 14.6% at the end of 1 year, excess body weight loss 40.2%, but more important, the HbA1c reduction occurred by almost 2%. And there was a reduction or stoppage of anti-diabetic medications in majority of these patients, and there were no device-related serious adverse events. So therefore, as far as metabolic endoscopy goes, if you ask me personally, this will be one of the techniques will probably endoscopists will start using routinely in the future, along with an endoscopic sleeve gastroplasty. If you also perform a magnetic anastomosis, you will have an excellent control of weight loss, along with a control of the increasing HbA1c or the patient's type 2 diabetes. Well, finally, to conclude, what are the conclusions? This very recent review article by Christopher Thompson in 2021, current state of bariatric endoscopy, if you want to see, what are the various modalities which are likely to remain? Intragastric balloons, of course, 5 to 15% total body weight loss. Then, of course, suturing of the stomach, you will have 15 to 20% total body weight loss. And the incision-less magnetic anastomosis probably will have a very good total body weight loss, and also it will cause a metabolic effect by reduction or reversal of the type 2 diabetes. DMR, as well as the jejuno-ileal bypass liner, is not likely to come into the market soon. In fact, this endo barrier or this bypass liner probably will never come. There was one device called Aspire Assist, which is already now discontinued and is no more used anywhere in the world. So therefore, friends, just to tell you that bariatric endoscopy is something which is an evolving specialty. And those of you who are interested in these patients of obesity and who want to contribute towards reduction of their weight, I think it's high time that you took up the technique of various bariatric endoscopic procedures, because it will form a part and parcel of any major endoscopy center in our country. Thank you so much.
Dr. Mahal, it is an excellent presentation as usual. I'm
Thank
Dr.
you.
Naresh Arora from Surat. I am a laparoscopic surgeon. Just I would like to ask you one thing. The patient is planning for a bariatric surgery sleeve, is planning for a sleeve. If he goes to a surgeon, by and large he will advise for sleeve gastrectomy. And if it goes to the endoscopist, he may advise for a sleeve gastroplasty. What is your opinion? What should be the criteria where one should go for endoplasty or when he should go a sleeve gastrectomy?
Very good question. My first answer is that bariatric endoscopist and bariatric surgeon should not work independently. They should always work as a team. You should have an obesity center. You should not have only bariatric surgery or have only bariatric endoscopy. For example, with whichever bariatric surgeon I've interacted, they have a large number of patients where they are trying to convince since last many years to undergo bariatric surgery for not getting anything done. So therefore, they advise these patients bariatric endoscopy. Then another issue, I spoke to some surgeons who are also performing bariatric endoscopy. You know what they told me? They told me that after they started doing bariatric endoscopy, their surgical procedures increased. Now, why did that happen? Opposite effect. The effect is that once you do bariatric endoscopy, patient loses around 15-20% total body weight loss. And once patient understands what happens after weight loss, that their body is getting transformed, their life is getting transformed, then these are the same patients who will tell that, oh, now this was fantastic. In 3 years, I lost so much weight, but now my weight is not reducing further. I want something better. So they'll go to the bariatric surgeon and they'll say, now you do a RUA bypass. So what I'm trying to tell you is that these are complementary procedures. They are not competitive. Endoscopic sleeve gastroplasty can never compete with cutting of the stomach. How can you compete with that? Because by cutting of the stomach, lap sleeve gastrectomy will have a 30% weight loss, total body weight loss. But is that really required? Do you want to take that 1% chance of leak? Because if a leak occurs, it is a nightmare. It's a nightmare for a surgeon as well as for the patient. And if that happens, that can suddenly stop your entire program. I don't mean that you should not do a laparoscopic sleeve gastrectomy. You should do it for certain patients. So normally what we do is, if we have a patient with a BMI of about 38, 40 and 40 upwards, we first tell them for your lap sleeve gastrectomy or a RUA bypass is better. But if they still get scared, they don't want to undergo, then we do an endoscopic gastroplasty. But anything below 38, 39, we advise them an endoscopic gastroplasty.
Sir, Dr. Ram here. What are the data on weight regain after ESG procedures?
Same like laparoscopic sleeve gastrectomy. See, weight regain starts happening after 1 year. And majority of the times we have found that two things happen. One is the sutures loosen up a bit. You know why? Because stomach is a mobile organ. Continuously it is contracting. And because of the contraction, there's tension on the sutures. And even though you have taken full thickness sutures, there's a little loosening. So when you do a scopy 8-9 months later, you'll find gaps in between the sutures. But you don't have to worry because the gastric emptying is still lower. It's already reduced. Even though the stomach has opened up in a few places, that doesn't mean that your result is negated. No. The gastric emptying is reduced. The patient has satiety. You tell the patient, now you just come on an OPD basis. I'll take 2-3 more sutures. Again, you'll go back to the weight loss.
So one more question. What are the side effects you have experienced? You said not significant side effects, but what patient complain after ESG?
A commonest complaint is, of course, a little bit of stomach pain, epigastric pains. Some of them have a lot of retching, vomiting. But that is if you have made it too tight. But same as lap sleeve gastrectomy, nowadays we don't make it too tight. We make it loose, a little bit loose. That means we leave some area in the stomach. We don't tighten it completely. That should not convert it to a high pressure zone. That is number one. And number two, all these patients nowadays, after a week or 10 days, we start them on pharmacological therapy of semaglutide. Nowadays, semaglutide is available in oral form. They can take a tablet. One tablet a day further adds to the additive nature of the weight loss because they further lose appetite. They become a little bit more nauseous. They start continuing liquid diet, little bit of soft diet. And achieving a 15 kilos, 20 kilos weight loss is not at all difficult in this situation. Pharmacotherapy combined with ESG now is the gold standard.
One more question. I'm Dr. Rahul Nayak. Sir, excellent presentation.
Thank you.
As per the presentation, the effect of the ESG depends, it acts on delaying the gastric emptying. Now we are leaving the fundus at its place, and which helps in delaying the gastric emptying. Have you or anyone come across any patient who has developed Barrett's metaplasia or esophageal malignancy after ESG in literature or anywhere?
See, ESG is a relatively young procedure, maybe 5 years from the time it was introduced, approximately. So it is too early to say whether these patients will develop. But I'll tell you, large hiatus hernia is a contraindication of doing an endoscopic sleeve gastroplasty. Why? Because if there is a very wide hiatus, then these patients will definitely have reflux. Whatever food accumulates in the fundus will all come up in the esophagus. But nowadays, we have got good endoscopic procedures to placate even the OG junction. If you do find something like that, then we go in and then we narrow down the OG junction also a little bit.
Okay.
We can do endoscopic anti-reflux procedure.
Because see, when one anastomotic gastric bypass was started somewhere in 2007 or 8, but gradually what we are seeing after 10 years that there are anecdotal patients coming up with the lower esophageal malignancy. And these are the patients which we are seeing or which are being reported somewhere. So the same thing which I wanted to know from you.
Yeah, so we keep these patients on follow-up. If the patient has a lot of symptoms of GERD, we keep on following them up. We do the repeated endoscopies. We don't allow anything to happen. We keep them on good quality PPIs. And if required, we can even loosen up a few sutures by cutting them. It's very easy to reverse the procedure. Just go in and cut a few sutures, the pressure reduces, and the GERD will stop.
So, sir, is it reversible after 3 years also? Means
Yes,
stomach
yes,
is again inflate well like earlier?
Yes, may not completely inflate, but it is reversible. There's only one contraindication. This procedure is not advocated in those countries where early gastric cancer is common. Why? Because once you have sutured the stomach, you will not be able to pick up early gastric cancer. You will not be able to study the gastric mucosa. So in countries like Japan or Korea, this procedure is not advocated because their incidence of early gastric cancer is very common.
Thank you, sir.
Hello. Good evening, sir.
Yes, good evening.
Sir, excellent talk. I learned a lot from your talk, sir. Sir,
Thank
one doubt is that, sir, among various balloons, which balloon you are preferring? And sometimes patient coming with a very next day not able to tolerate balloon. So how you decide how much volume you should inflate? Which balloon you are using routinely? And if it occurs, then how it can be treated?
See, I am a fan of the Spats balloon because it's an adjustable balloon. Because I realized one thing that Indian patients don't tolerate large size balloons immediately. They start retching, vomiting, they come to you for removal of the balloon. So what we do is, with the Spats balloon, we inflate only 350 cc's first. 15 days later, we call. Till that time, patient is already adjusted to 350. We make it to 500. Again, 15-20 days later, we call and make it to 800. This way, if you do, the patient tolerates well. Second trick is that in the first 1 week of the placing a balloon or a gastroplasty, we give the patient a very strong antiemetic, that is aprepitant. We don't give them just ondansetron. If you give them aprepitant, they don't have vomiting. They don't have nausea. It is an excellent antiemetic which is given for chemotherapy.
Thank you, sir.
Anybody in the audience would like to ask the questions?
Very good evening, sir. I'm Dr. Lavkush. Fantastic talk. Very
you.
enlightening.
Thank you.
Sir, I just wanted to know if there are any don'ts as far as the patient is concerned after you do a balloon procedure.
Don'ts means I didn't understand.
Anything that you advise the patient against? I mean, if any precautions that the patient has to take.
The only precaution, because there are some patients which are treated, they wanted to dance. They wanted to join dancing classes. Now, when you put a balloon in the stomach, if that patient starts dancing, that balloon is also going to dance in the stomach, and that patient is going to have a lot of pull on the stomach and pain. So that's the only thing I tell them, that don't do activities where you need to undergo dancing or jerky movements like playing badminton, for example.
Anybody else? Please come forward, or you can raise the hand. So we would like to thank Dr. Amit Mahadev. He is a chairman of Baldona Institute of Digestive Science, Bombay. First, I love to introduce that he is the first to introduce the poem and STER and ARMS in India in 2012, and he is the winner of first World Cup of endoscopy held in Chicago in DDW, and he is also the member of jury in the DDW held in 2016, sir. Excellent, sir. Thank you.
Thank you.
Thank you, sir. Saumin here.
Hi, Saumin.
Thank you, sir. As usual, is very inspiring to just to see you. Here is different thing. Okay, so you just told it is not a competition. It is a complementary to each other. So tomorrow, unfortunately, sir is busy, but we have divided a 3 group. One is surgeon. 4 surgeons will be there because sleeve gastroplasty is gastrectomy. There are means cystogastostomy, gastrojejunostomy. So these are the means that can be done by the surgeon also, and that can be done by the endoscopist also. So in each chairperson, 4 surgeon will be there, 2 endoscopists will be there, and 2 are the umpire. Monk, I can say, sadhu type. Okay. And I have chosen Dr. Naresh and Dr. Vishmit for this monk. So no bias, but we have to complement each other. Okay. It's a lots of learning then. Okay. And
But,
sir, please.
Saumin, the fact that you have kept umpires, that means there is going to be a result of one side against the other. So don't make it a debate.
That's why.
Because if it is a debate, then it becomes competitive. So make it complementary.
What happened, sir? I have used this word umpire because today, unfortunately, otherwise it would India versus Pakistan. Okay. So I changed the team. I will keep like this: better bowlers and umpire. But once India exit, then I keep monk, sadhu type. Okay. So they remains calm. They keep both the side calm and give the neutral statement. Okay. So
India is doing the gastroplasty or Pakistan is doing gastroplasty?
That monks will tell. Particularly, monks will tell that practically this patient require gastrectomy or gastroplasty, and each has its own merits and demerits. And our second lecture, whatever the sir that first introduced the poem and winner of the first award, but the journey of Amit Mahadev sir, I have heard from other person, but is excellent. But I request you, sir, for next time when we organize our lecture, how a surgeon become master endoscopist, and you can just heard his story, nothing else. Okay, then you can see what is the patient persistence is there, what is the patient is there. Okay, because I met her during the speedboat, and even I felt at that time not a single time his eye moved from the screen while he is doing the procedure. Okay, so next time this due will remain, sir.
Thank you, Saumin. I will definitely come. Thank you. Bye.
Thank you, sir.
Congratulations once more, and best of luck for your meeting tomorrow. Best of luck.
Thank you, sir.
Bye.
Bye, sir.
Bye.
Recently, just Dr. Rakesh Kalpala sir and Dr. Kapil Jambal sir joined the meeting. So just to introduce that, Dr. Rakesh Kalpala sir is from renowned gastroenterologist from AIG hospital, and he requires no introduction. He has tremendous publication on bariatric procedure, endoscopic bariatric procedure. And Dr. Kapil Jambal sir, he is from Haryana, Gurgaon, and he has also a tremendous publication regarding various endoscopic procedure in the gastroenterology. Now
we also welcome Dr. Raju Mehta sir.
And now next talk will be by Dr. Rajesh Senani sir, who has 25 years of experience in the field of gastroenterology. He is special interest in field of reflux, constipation, and GI motility disorder. Next talk will be by Dr. Rajesh Senani sir. The stage is yours, sir.
Sir, Sir,
Okay.
just one minute, sir.
Yeah.
Sir, I would like to invite chairperson, Dr. Veenu Jadhav, Dr. Anurag Nema, Dr. Lavkush Sharma, Dr. Kiran Patel, and Dr. Jay Choksi. Please come forward and occupy the front seats.
Good evening, friends, and thank you for inviting me to Surat. Thank you, Saumin. And it's great to see old friends here all our friends are sitting in the second row. Rajiv and all the chairpersons are in the first row, but it's very nice to be back in Surat. So I know I'm talking to a predominantly surgical audience, and I think my talk is also based, I'm a gastroenterologist, but I'm going to try to shed some light on, does manometry and pH, these two tests before fundoplication, does it alter the surgical decision? Some of you already know what manometry is because there are so many centers in Surat which is doing it. It's a pressure measurement within the esophagus from the pharynx to the stomach. And pH studies are a test which measures how often and for how long stomach acid actually enters the esophagus. So how does manometry help us in GERD? It tells us about the morphology and integrity of the lower esophageal sphincter or the esophagogastric junction. It tells us about esophageal body motility. It tells us if the esophagus is damaged with long-standing reflux, is there a reserve of peristalsis? It helps us to identify why patients are refractory to proton pump inhibitors. It helps to localize the upper border of the lower esophageal sphincter before we do a 24-hour pH, especially in patients with non-erosive reflux. And it helps us identify why patients continue to have symptoms after anti-reflux surgery. So we'll go each one of them one by one. So we know that the manometry catheter is passed transnasally. We tell the patient to swallow water. It has 16 to 32 channels, and the high resolution zone, especially along the lower esophageal sphincter. And basically what it gives you is this multicolored thing. The different colors are the different pressures. And what you can see at the top here is the upper esophageal sphincter. What you can see down is the lower esophageal sphincter. And this wave-like contraction is the esophageal peristalsis. The blue lines are the deep inspiratory. And as the peristalsis comes down, you can see just before here, the lower esophageal sphincter relax. And then there is augmentation of the lower esophageal sphincter after the peristalsis. So this is a normal esophageal contraction. So let's now go into each of the 6 points I told you. How does manometry help define the esophagogastric junction? We measure the esophagogastric junction usually in quiet respiration for up to a minute. We measure something known as the lower esophageal sphincter pressures, and also now we can measure what is known as the EGJ or the esophagogastric junction contractile integral. Just a big word, but that's the software uses that to calculate that metric for us. Okay. The lower esophageal sphincters are always referenced with respect to the intragastric pressures. We look at what is known as the respiratory inversion point. I'll come to that later. And we usually say that a normal lower esophageal sphincter pressure, that's what the surgeons look at, is 10 to 25. Anything less than 10 is a hypotensive LES. But when we look at the contractile integral, that is a value of less than 25, usually suggests that the lower esophageal sphincter is significantly weak. So the Lyons consensus and the Chicago 4 classification basically have described the EJG morphology depending on the type of the lower esophageal sphincter. So if the lower esophageal sphincter and the crura overlap, it is type 1. If they are less than 3 centimeters apart, that means like a small hiatal hernia, it is type 2. And if it is more than 3 centimeters apart, then it is a type 3. But the type 3 has 2 subdivisions. In subdivision type 3A, we measure something called as the respiratory inversion point. But what does it tell you? It tells the surgeon whether the crura of the diaphragm are contributing to the lower esophageal sphincter or not. While a type 3B tells us that the crura is not really working at all, and the respiratory inversion point is occurring only at the lower esophageal sphincter. And I think this is important information for the surgeon to help whether he needs to strengthen the crura during the surgery. Then we look at how the manometry helps to identify the esophageal body peristalsis or the motor function. The one on the top here shows that this is a weak peristalsis. You can see the break. On the right side here is a complete absent peristalsis. And the one low here shows that there is good peristalsis here, but there is a big gap. So a gap of more than 5 centimeters tells us it's a fragmented peristalsis. So all these are different types of defects in the esophageal peristalsis. And how does this help us? Sorry, before we come to that, I would just like to tell you that there is another condition called as scleroderma. And this is very important for us as physicians and surgeons to understand, because this is different from a simple absent peristalsis. In these patients, you have peristalsis in the upper third of the esophagus, that is here, but there is no peristalsis in the lower 2/3 of the esophagus, and there is a hypotensive LES. And usually surgeons are not happy to operate patients of scleroderma because of a significant high risk of post-operative dysphagia. These patients are usually managed with PPI and a good control of their autoimmune disorder. And this subgroup of patients need to be identified before you consider a person. And who do you look at? You usually look at the young women, because scleroderma is 8 times more commoner in women than in men. So you should suspect it in a woman. Simple things you will see that they have poor mouth opening, they have mask-like facies, they don't blink their eyes frequently enough, and if you pinch their skin, you will see that it is stuck to the underlying submucosa. So these are simple clinical examination findings which we need to look at to define whether the patient has scleroderma or not. So when we come to the esophagogastric junction, which is impaired, which is weak, so you have a low LES pressure, what does it do to the body? It causes frequent TLESRs. What is TLESRs? Transient lower esophageal sphincter relaxation. Normally, the lower esophageal sphincter should not relax when you're not eating or swallowing. It does occasionally, but if the frequency is high, then the patients are more prone to reflux, especially if this is post-meal. And this commonly occurs if the stomach is over distended, or when there is an increased when there's a poor gastric accommodation. So if you have somebody with increased transient LESRs, you have a weak LES, or you have an hiatal hernia, these things predispose the patient to postprandial reflux, reflux esophagitis, and increased acid exposure of the esophagus. If there is body dysmotility, then we say they have ineffective peristalsis and they have a defective secondary peristalsis. What is secondary peristalsis? When you swallow something and if food remains in your esophagus, without another swallow, the esophagus body generates a secondary peristalsis to clear that bolus. And this is usually absent, or this is weak in patients who have a weak body peristalsis. So how do you measure that? How much reserve is there? So you have a patient of reflux and you have ineffective motility. So the question the surgeon always asks me is, should I do a Nissen's fundoplication, a 360, or should I do a 270? Is my patient going to get post-operative dysphagia? So how can I objectively answer this question? We do what is called a multiple rapid swallow, where 2 ml, 5 swallows of 2 ml each in rapid succession with less than 2 seconds between each swallow is given. And what are we looking at? Look at the right image. We are looking at, this is first swallow, second swallow, third swallow, fourth swallow, and fifth swallow. And after that, the patient generates a peristalsis. If this peristalsis contraction amplitude and DCI is more than the average of the 10 that we have recorded before, then we say that this patient has a good peristaltic reserve. And if we give this information to the surgeon, he knows that this patient's chance of post-operative dysphagia is going to be less. So he can plan his surgery accordingly. So that's what was the first line, that if the MRS swallow has a good peristalsis. So what happens if the post multiple rapid swallow, there is poor peristalsis? So I'm going to tell the surgeon, this patient has a poor peristaltic reserve. He has going to have a poor efficacy with any drug therapy that he receives. This is a risk factor for post-operative dysphagia. So it's a relative contraindication to do a full 360-degree wrap, and they should consider a 270-degree toupee. And more importantly, the patient should be told, because the patient always asks, doctor, after you do the surgery, am I going to get better? Yes, your reflux will get better, but we are not sure, because you have a poor peristaltic reserve, whether your esophageal motility will come back to normal. So this is the information, additional information we can offer our surgeons. And then what do we do in a patient who has refractory GERD? There are different studies when they looked at a whole lot of patients. I think this was 1,000 patients or plus. I don't remember the exact number. When they were evaluated to see in preoperative esophageal manometry, what did they find? They found that 3% had absent contractility, 3% had spastic disorders like distal esophageal spasm, another 2.73% had achalasia. So if you don't do a manometry before you do a fundoplication, these 9% of patients you're going to miss, and these are the patients who are going to be unhappy, or the patients are going to come back with major post-operative issues. What happens if you take a group of achalasia patients? I think this was a group of 65 achalasia patients, and when they took their history, they said 55% of them or 60% of them actually present to the physician with heartburn as their symptom, 75% have regurgitation, and almost 25% of the achalasia patients were initially treated as reflux for months to years before they actually were diagnosed to have achalasia. So if you have somebody with dysphagia, your threshold, and you have nothing on endoscopy to explain the dysphagia, your threshold for doing manometry should be early, to pick up these patients early so that you prevent treating them as GRD instead of achalasia. So this is how perioperative manometry will help. If you look at the upper one, this is a spastic disorder of the esophagus. There's a lot of black, means a lot of high pressure contraction. This is what we call as jackhammer esophagus or hypercontractile esophagus. They will commonly present, they may have reflux, and chest pain is their predominant symptom. The lower one here is distal esophageal spasm, where the middle and the lower third of the esophagus contract simultaneously. They will also present with dysphagia and chest pain. And the lower left over here is achalasia. Achalasia on manometry is of three types. We have type 1 achalasia, where there is no significant pan-esophageal pressurization. If you have a lot of pink along this, then you say that this is a pan-esophageal pressurization. You have a lower esophageal sphincter here, which is not relaxing, like I showed you the first one. There is no relaxation here when the patient swallows. There is no wave-like peristalsis. Yeah, and this is a spastic esophagus. So all these three are the three different types of achalasia. They have different responses. I think when they will discuss tomorrow on POEM and things like that, you will learn more about this. So how does manometry help to localize the upper sphincter? We know that patients of reflux will have heartburn and regurgitation, and we usually clinically decide, does my patient have reflux based on whether they respond to PPI or not. But when we do endoscopy, almost 50 or 60% of them who come with reflux symptoms actually have no erosions, no evidence of reflux. And in these patients, if we need to prove, or if these patients we want to send them for fundoplication because they have volume reflux or significant reflux and they are on long-term PPI, then we need to do a 24-hour pH study and to localize the upper end of the lower esophageal sphincter, which is very important in a pH study, because accurate placement of a pH probe 5 centimeters above is the most important thing to give an accurate report. So a manometry helps us to determine that, and it helps us to localize the lower esophageal sphincter. This is how a patient is sent home with a pH catheter and a recorder, and he comes back after 24 hours, and we measure the data as to how much reflux is coming up. This is how a pH study looks like. This one on the top is normal. This black line here is a pH of 4. So few drops in pH below 4 is physiological. multiple drops of more than 4 to 6% in 24 hours is pathological. And these multiple arrows on the top over here is symptom correlation. So if your symptoms correlate with your drop in pH, you say that this patient has significant reflux with good symptom correlation. So again, the Lyon consensus says that you should have at least 4% of reflux in 24 hours. More than 6% is diagnostic, and you should have a good symptom correlation. There are two indexes, symptom index and symptom associated probability. If they correlate well with reflux episodes, then you can say this patient has significant reflux. We also do impedance for these patients, where you look at acid reflux and non-acid reflux, and they have different normal values as mentioned over here. There are two new metrics that we can look on pH impedance. One is the post-reflux induced peristalsis. So that is after you get an episode of reflux, does the esophagus generate a peristalsis to clear the esophagus or not? And this determines the integrity of the esophageal peristalsis. And this is another metric which tells us whether this patient has significant reflux or not. And we can also look at what is called the nocturnal impedance. This nocturnal impedance is low in patients who have erosive esophagitis, while it is normal in patients who have functional heartburn or healthy. So these are two new metrics. We still don't know where to use them in our armamentarium to diagnose and reflux, but as more data comes in, we'll be able to use it. So the last point is, what is the role of manometry in symptomatic patients after anti-reflux surgery? It helps us to diagnose patients who have post-operative dysphagia. We usually do a barium esophagogram and a manometry, and we do provocative tests where we give them 200 ml of water to drink and we see what happens. We give them solid meals with bread or marshmallows to see whether this holds up and whether there is any pressurization in the esophagus. We can also do a manometry along with fluoroscopy to actually see the transit time, to see where the holdup is and what happens to esophageal peristalsis at the time of the holdup. So my last slide is manometry and pH have a very definite role to help you to diagnose patients, especially of non-erosive reflux disease, to be sure that you're not missing a patient with spastic esophagus or achalasia before you send them for surgery. And more importantly, you want to prove that the symptoms are related to reflux. If the patient has heartburn, regurgitation, and cough, and he says the heartburn and regurgitation is not bothering him, but it's the cough is what is bothering him, you want to be sure before surgery that there is a good symptom correlation of cough with his reflux episodes. And you want to know which patients have a poor peristaltic reserve. So those patients you don't want to do a complete Nissen's fundoplication, and you would like to do a 270-degree ramp. Thank you very much.
Hello, good evening.
Good
Thank you for such an excellent talk. You made a very good point-wise presentation to tell us the benefits. A couple of questions. Generally, most patients who visit in OPD with symptoms of GERD, they are diagnosed clinically. Endoscopy is done, and then we treat them with medicines. Most of them by medicines upfront. And at least it was my impression some time back that we advise manometry only if we are thinking of a surgical intervention or patient wants surgery, then only manometry is advised. But as you told in your presentation, I also had a patient who was treated as GERD for many years, for 3-4 years, endoscopy is done many places. And only at the time, just before we wanted to do an anti-reflux procedure, we did a manometry and found it to be a achalasia patient. And then we had done a myotomy and patient is fine. So I think it is better. When should we do manometry in GERD patients, even if we are
So I think if they respond well to therapy, I think it's fair not to do it initial part. But if you have somebody who's on long-term PPI, relapsing frequently, you want to offer him surgery, I think the surgeons will always complain that we gastroenterologists don't send them enough patients for fundoplication. And most of them are patients who incidentally land up with them. And I think we need to also look at our own OPD where we need to sub-select the patients who are the volume refluxers, because these are the ones who really benefit from surgery. They're sitting propped up, can't sleep for 4 hours. And even though their heartburn may be responding, but their regurgitation is not responding. I think these are the people we need to send earlier, or at least offer to the patient. We need to make because when the patient reaches the surgeon, they said, no doctor ever told me, I've been seeing 5 gastroenterologists and nobody even told me there's an option for surgery. So I think we need to counsel our patients earlier, especially if they are on long-term PPI and either they are poorly controlled or they are volume refluxes. The volume refluxes, I have a lower threshold to send them for, because they are the ones who really do extremely well.
And one more question, in one of the slides you told about symptomatic patients after anti-reflux surgery.
Yes.
So when would you like to do manometry after surgery? I mean, what will be the best duration? 3 months, 6 months?
No, so we don't routinely do it. Only if
in the
they are not
symptoms.
if they have, yeah. So the first 4 to 6 weeks, they are anyway on a soft to liquid diet. You're waiting for the edema to settle. But say at 6 weeks, 8 weeks, they are the ones who are really, some of them will have gas bloat as their symptom. But the ones who have dysphagia, those are the ones you want to really look at. So I would wait at least 4 to 6 weeks before I want to do it, unless rarely we found people within a week or 2 weeks who had come near total dysphagia, where we knew there was either an inadherent vagal trauma, or there was a very tight wrap, or the wrap had slipped, a migration of the wrap. And we have had one very rare case where the patient had actually, because of this vagal injury, so patient was developing gastric outlet obstruction symptoms. So very uncommon, those cases, but I think we need to listen to our patient, and if we feel that their symptoms are significant, we need to look for it.
So, good evening, sir.
Good evening.
I'm Dr. Lavkush. Fantastic talk. My compliments. Just one question. The MRS study that you mentioned, is it a part of HRM, or you have to specially mention it?
No, it's part of the HRM. So if you have normal esophageal motility, then there's no real role of doing the MRS. But if I have ineffective motility, then I would do the MRS at the same time for all my patients. There are some centers where sometimes maybe the technician is doing it, and if the technician didn't realize because the doctor comes and reports it, then there may be an issue. But that's why now, as per Chicago 4, it's coming more as part of a standard. The newer software, in fact, literally makes it mandatory for you to do an MRS at the end of a routine surgery. So I think as people will upgrade their softwares, everybody will land up doing it mandatorily. But if the physician is present there, then you pick it up when you're doing the test. So we do it for most of our patients.
Thank you, sir.
Rajesh, I have a question.
Yeah, sure.
So as usual, you made it look very simple and thoroughly enjoyed your talk.
Thank you.
So my question is regarding jackhammer and diffuse esophageal spasm. Sometimes these are labile diagnoses. So do you feel you repeat them after, say, a couple of months, that once you diagnose with jackhammer esophagus, your manometry shows, or one?
So they are
goes with
labile.
another?
I think there are patients who who have been following up for years now with jackhammer or distal esophageal spasm. I think a lot of them are also reflux induced. So almost all of them, though I may be treating them with a calcium channel blocker, I would put them on PPI also. And I realized that that's where the thing is. And if I have repeated their manometry at 1 year or things like that, they still have the findings, but they have the jackhammer, but they don't have symptoms. So it's not that every time they have a hypercontractile peristalsis that they get chest pain, but they continue to have the spastic disorder. And if they fail therapy, then we think whether we should send them for POEM. But my threshold somehow is a little lower. Why? Because I think we have been treating them for a decade before POEM came in, and most of them did reasonably well. So I like to sub-select the patients who are not responding or who cannot take calcium channel blockers or are developing or are concerned nowadays because of the media. The people are concerned about PPI a lot, and I have a lot of patients telling me that they want to stop their PPI because they feel they're going to get kidney failure and things like that. And the cardiologists and the nephrologists are telling them not to do. So those subgroup, if I'm sending them earlier for a definitive therapy like POEM, then, but yeah, it's labile. And I've had a few jackhammer who turn into like an EGJ obstruction and turn into achalasia. So they've come back after 6 months, 1 year with worsening dysphagia. And then we've had to do either a POEM or a lap myotomy.
Sir, one more question. Most of the time, I think manometry must be done at least before the surgical intervention we are planning for, or we are planning for anti-reflux surgery. So
Yes.
what is the, whether nowadays many endoscopic techniques are also there for endoscopic anti-reflux procedure. So manometry is required.
Yes,
that also,
yes, absolutely. Manometry is required because you want to confirm the diagnosis, you want to know how your lower esophageal sphincter is, and you want to know your esophageal motility.
Sir, one question.
Yeah.
Do you think reflux have any impact on the motility of the esophagus? Because most of the time, our symptomatic patients, when we do or where we get done the manometry, they show ineffective esophageal motility.
Yes, yes. So long-standing reflux patients have ineffective motility, and now that we are devised this multiple rapid swallows, we know those people with a good reserve their motility may return after lap fundoplication or endoscopic fundoplication. So once you correct the reflux, or if you have somebody on long-term PPI, and we have done after 1 or 2 years a repeat manometry, you see that the number of if they had 10 or 20% only normal peristalsis earlier, now they may have 50-60%. But there are some people in whom it doesn't improve at all, and they have absent contractility or ineffective motility even after controlling their reflux. I think that subgroup is the one who have this poor peristaltic reserve, but it's difficult to predict otherwise how they're going to do.
Do you recommend 360-degree complete floppy fundoplication in these patients, or partial?
So if they have normal peristaltic reserve with good motility, yes, we do a 360. But if they have ineffective motility with a poor reserve, then our surgeons would do a 270.
Thank you, sir. Any?
No, anybody who comes with reflux to us, first is once a day. If once a day doesn't work, it's twice a day. And if twice a day doesn't work, I try to switch the PPI. But the minimum, I think what we all, because either we feel that the patient won't come back, I think we gastros have to change the way we prescribe PPIs. We never prescribe an antibiotic less than 5 days. But we write PPI for 15 days and 1 month. And you open any textbook, the minimum duration, if you feel, is 6 to 8 weeks for reflux disease. There's nowhere it is written 2 weeks, 1 month, or anything like that. So I think we are not prescribing long enough. So patient takes for 2 weeks, gets better. After 15 days, he gets it. He may come back again or self-medicate. Then he says, this doctor is not good because every time it is coming back. Because he has not been told that 30% will relapse. He has not received the 6 to 8 weeks therapy. So his chance of relapse is higher than the 30%. It's probably more, 50. When you give 6 to 8 weeks, your risk of relapse is 30%. So with a short thing, so I think the single most important, because once I was giving a talk to the GPs and they asked me, what drug do you have access to that we don't have? And I said, we have exactly the same drugs. The GPs are writing 3 days because they want to see the patient again after 3 days. But that's why so if the patients do well, then again after 10 days, they're not willing to give a 6-week prescription. And we physicians are not willing also to give a 6-week. We are giving 2 weeks, 4 weeks. You look at any gastroenterologist, all our colleagues, you see our own prescriptions. We ourselves are at fault because we are not giving long enough. I think if you give long enough, you don't need the DSR, you don't need the L, you don't need the itopride. You don't need anything because there is no data to use prokinetics in a patient with pure reflux disease if he doesn't have dyspepsia, if he doesn't have gas, means if he doesn't have functional dyspepsia, there is no reason to give any of the probe. And you ask any of the company people outside, their DSRs outsell the PPI in volume in the whole country. So it's obviously that all of us are wrongly prescribing. There's no question about it. Yeah, so before we do a 24-hour pH, we stop PPI for 7 days. That's mandatory, always. So with PPI, you can do what I told you is the impedance study, because that measures acid and non-acid reflux. But you have to, in whom do you do it? It is because it depends on the question you're asking. If you want to find out, does my patient have reflux? Then you have to do off PPI. If there's a patient of Barrett's esophagus on PPI and he's having symptoms, or his Barrett's is increasing, or he's getting GI bleed or something, anything, then you say, is my PPI working? So then I will do an impedance study on PPI. But 9 out of 10 times I'm asking the question, does my patient have reflux? So you have to do it off PPI.
Hello. Good evening, sir.
Yeah.
Dr. Dinesh Prasad.
Yes.
Listening this discussion after your presentation is very excellent. I have one question.
Yes.
It seems as if this manometry is required every time before surgery.
I hope you have to do the lab fundoplication only once.
I'm doing lab fundoplication since more than 15 years.
Yes,
sir. Excuse me. Dr. Rakesh has another meeting online at 10 p.m. Okay, so he's next speaker. So you can interact in dinner if possible. Okay.
Yeah, so it has to be done before every surgery.
No, I have objection.
Yeah, okay, we can sort it after.
In dinner, you can solve it.
Thank you, sir.
So
thank you, chairpersons.
Our next speaker requires no more introduction. Dr. Rakesh Kalpala, sir. He has 15 years of experience in gastroenterology. His area of interest is endoscopic bariatric procedure, endoscopic sleeve gastroplasty. Next talk will be on, can endoscopy replace fundoplication surgery in future? The stage is yours, sir. And for that,
I would like to invite Dr. Dinesh Prasad, Dr. Bhavin Bua, sir, Dr. Rahul Gupta, Dr. Ronak Malani, and Dr. Rajiv Mehta. Sir, please come and occupy the front seats. Sir. Sir, now the stage is yours.
Okay. So good evening, everyone. Thanks Saumin and his team for calling me and giving this opportunity. So I think Saumin has started this whole feast of creating controversies, or rather creating complementary things. So he asked me to speak on, can endoscopy replace surgery for hiatus hernia in future, with 90% of the surgeons being in front of me. So I'll try to balance and then show you the figures and facts what are there in literature with scientific evidence. Yeah. So what we have to learn in these patients with GERD, which Sainani also has told, the PPI refractory or PPI dependent patients, is you categorize them into 4 phenotypes. GERD is no more an ambiguous diagnosis, and it's very crystal clear telltale evidence is there once you perform an upper GI endoscopy, manometry, and 24-hour pH impedance, and categorize the patients into either of these 4 phenotypes: erosive reflux disease, non-erosive reflux disease, reflux hypersensitivity, and functional heartburn. I'll tell you why. With this categorization, you have a clear way of which person needs which treatment. And the unmet needs in GERD, or the ones where you need these procedures, either an endoscopic or a laparoscopic. The main difference between an endoscopic and laparoscopic is a large hiatus. Obviously, you guys are the masters. In a small hiatus, we do have evidence-based medicine, which I'll tell you in the next few slides. So the unmet needs of the refractory GERD or the PPI-dependent GERD, long-term PPI use, anti-reflux surgery, which people don't want to, and of course, a volume reflux, which is mandatory. So these are the 4 unmet needs where we do have an established role of endoscopic anti-reflux surgery. And an ideal patient, I'll re-emphasize again these things in the last slide, is the symptomatic GERD, PPI dependency, grade A or grade B esophagitis, small hiatus hernia, and pH less than 4 for more than 4% times. So if you see the endoscopic anti-reflux modalities, it's divided into 3 categories as of now. One is the radiofrequency ablation, which kind of gone to obsolete. Transoral fundoplication, where you alter the G junction anatomy, and mucosal resection or ablation, where you don't alter the anatomy, but you just do some things around the G junction, which I'll tell you. So coming to STRATA, as I told you, this is a non-ablative radiofrequency ablation of the G junction, and it was there in 2000, 2003 in the market. Then it went back and came in 2014, 2015. But again, I personally have had experience on this, but don't believe in this as a standard of care in current endoscopic anti-reflux modalities. So this is a simple technique where you ablate the mucosa 4 levels above the cardia and 2 levels below the G junction. Literature wise, there is a 4 and 8 year follow-up. We ourselves have done from our group a randomized controlled trial initially and published a pilot study. But again, this was of course endorsed by the SAGES and the other bodies. But again, I personally believe if at all it has to be considered, it is only in people who have got a hypersensitive esophagus, that is reflux hypersensitivity. It might work, but we don't have any evidence on this. The other extreme is a mucosal resection or ablation, which many of our medical gastro colleagues do and know about it. The one is the anti-reflux mucosectomy for GERD. This is again coined or started by Professor Inoue group in Japan. And this is how it is done. It's a very simple OPD based technique where you rotate, put the scope in retroflexion position, and then ablate, do the mucosectomy by creating a bleb, like how you do a ESD or EMR, and then you do the you snare the mucosa with a polypectomy snare, but you don't do it completely 360 degrees. It has to be partial, around 180 degrees. And this is a very simple, safe technique. Only thing is, as you see here, 270 to 290 circumference is being covered. Only thing is, in the long term, there are incidents of strictures, fibrotic strictures. But otherwise, the data is also initial study again by Inoue group, where they have found improvement in the quality of life and also improvement in the symptomatic indices. But and we also did a couple of cases, but as of now, from past 2-3 years, we are seldom doing this as a standard of care in our unit. The other one, which is commonly done, which I believe firmly that it is going to take a big role, but of course, in a subset of patients, I'll tell you which subset of patients, is a anti-reflux mucosal ablation, which is called hybrid APC. Very easy OPD based technique, hardly takes 10-15 minutes and can be done by any average endoscopist with a minimum setup of a simple upper GI scope and a APC machine, that is whichever company you prefer to. So what we do is again same anti-reflux. I'll run the video fast for want of time. So as you see here, we create a bleb by injecting methylene blue with saline, and then you start doing a simple APC catheter, a forced coagulation of 100 wattage with 8 ml per minute flow, and you do around 290 to 320 degrees ablation. Like what you can tell in simple language is you leave the scope diameter non-ablated, and then you do it from along the greater and lesser curvature. I'll just show you at the end how it looks. It hardly takes 10-15 minutes. As you see here, this part is left behind and 320 degrees is ablated. Again, this is discovery or invention from the Innova group. We at AIG, along with the University of Kansas Pratik Sharma group, we are doing a randomized control trial on this. You just started the study. Otherwise, we have had experience which is published in ESG days or interim data from our group, where we have found significant improvement in the quality of life, heartburn, and regurgitation score. Of course, no improvement in the acid exposure time, unlike other modalities. So this is how it looks at 1 month and 3 months, a nice scar which will close the GE junction. But I'll tell you in which cases you need this and in which cases you might not have a benefit with this after some time. And the third is the transoral fundoplication. This is one thing which I can say that it is like the surgical fundoplication, because this is the only modality or in which we alter the GE junction anatomy. And in this, the commonly used is the Usofix or TIF, what is FDA approved and widely used in the centers across the US. So there's a robust data on this. There are 3 randomized control trials on this TIF, and TIF is definitely a standard of care proved beyond doubt with literature, strong evidence that it is at par with fundoplication surgically, but again with a small hiatus and high volume reflux episodes. So these are the RCTs published on TIF, and this is, as I told, it's proved beyond doubt. And the second device is one which is currently widely practiced in India. We have few of our colleagues who do it regularly. And this is one very promising device called Gerdex from Germany. And I'll just show you a short video. Again, OPD based procedure, very simple, easy to do. You have a separate dedicated device for this, which is mounted inside with, and you need a pediatric scope to put into the channel. And then what you do is, as you see, it's a small hiatus hernia. We take 2 plications, one at the greater curvature and one at along the lesser curvature. This is how the device looks externally, and this is how it is being mounted. You just put it inside. This is the small ultra slim scope which is used to navigate and then direct what you're doing. As you see here, the first plication is taken along the greater curvature and the second along the lesser curvature. So it hardly takes, I think, 15 to 20 minutes. You need 2 operators, one the main endoscopist, one the assistant. And as you see, the first suture is being deployed, and now the second suture will be deployed along the, sometimes it overlaps, sometimes you can put it across. And as you see here, it typically looks like how you guys create a fundoplication wrap. So the data on this is again robust. We from our group have got the publication in Gut in 2022, which is the first randomized control trial on this device, where we have taken 35 patients in each arm, and then we did this procedure and observed the patients at 0, 3, 6 months, 9 months, and 12 months. We have found significant improvement in the quality of life index, which is the main crux what we want in this subset of patients. And also we have found improvement in the symptom indices from baseline till consistent till 12 months. And we also have seen the improvement in regurgitation and heartburn scores. Of course, again, like any other procedure, PPI dependency has not shown any statistical significance, but around 40 to 50% were independent of PPI. So this is on the Gerdex, and this is only RCT being published. And of course, TIF has got 3 RCTs. We need more. And Muse again is a device from Israel. I don't want to spend much time on this. This is not currently commercially available, but it is like the fundoplication device, which I told you earlier. And comparing these 3 existing fundoplication devices, definite concrete data with TIF, and Gerdex is also having a good amount, because RCT again is a level 1 evidence. So algorithmic approach in this, before concluding the next 2-3 minutes, symptomatic GERD, so you give empirical PPI therapy, they're not responsive, do an upper GI endoscopy, but many of them quite often skip this and then do an upper GI endoscopy because they come after taking PPI, especially over-the-counter PPIs. And if it is erosive esophagitis, then optimize the PPI therapy and then try to treat them. And if they don't respond, then you have the modalities which can be endoscopic or laparoscopic. And mandatory is, as some surgeons pointed out in the last talks. So my sincere advice to all the audience here is don't do, please, any fundoplication, either it is surgical or endoscopic, without meticulous workup. It's like putting your foot in a grave. Because if the manometry shows, as Rajesh told, ineffective esophageal motility, that patient will never improve with any of the application, either surgical or fund or endoscopic. And if the pH impedance shows a high volume reflex, only then they will improve. If they have a low volume reflex, the result is zero. So please, when you do, or if you don't have this armamentarium of manometry and pH impedance, you probably can refer to your medical gastro colleagues like Saumin and all, they have these things. You do this endoscopy, manometry, pH impedance, then you decide whether he needs that or not. So that's very mandatory. And so clinical situations where, as I told you, the endoscopic anti-reflex procedures are helpful. Patient selection, very, very important, as I told you in the last sentence. And the best patients are patients who respond to PPI therapy. Probably PPI refractory therapy patients, they may not respond to these modalities. And erosive esophagitis patients who are not willing to take long-term PPIs because of, there are a lot of articles from Lancet and top journals saying that long-term PPI leads to gastric malignancies. So now it's actually easy to convince your patient to do some modalities like endoscopic and fundoplication with this data. And as I told you, the last two phenotypes, reflex hypersensitivity, functional heartburn, please, please, please don't do anything. What all these last two subset of patients need is psychological therapy with probably triptomer or amitriptyline to decrease the hypersensitivity of the esophagus. And I am saying it's not a panacea for all these things. You do have limitations because these modalities have shown improvement in the symptom indices and also objective parameters like reduction in acid exposure time, but normalization of acid exposure time is not shown in any of these things. For that matter, even the surgical fundoplication also. And need for PPIs could not be eliminated completely in most studies, as it was told. And there are lack of comparative studies within the fundoplication group methodologies and also between the ablation and between ablation and fundoplication. So you need a lot of data comparing head to head on this. And as I told you, GERDX and TIF have got RCTs accepted. AMA and the other modalities, they don't have any long-term clinical studies. And as I told you, you need a significant improvement in documented subjective and objective both for all these modalities. And as we all know, GERD is a personalized medicine. There is no one hard and fast theoretical rule that so-and-so person goes to so-and-so. Symptoms, response to medicines, the anatomy of GE junction, physiology of the person, and psychological stress, more important, as I told you. That's very, very important. So the question of can endoscopy replace surgery for a hiatus hernia in future? I say yes, but only in this subset of patients, with due respect to you surgeons as the masters in laparoscopic fundoplication. Thank you.
Hello, good evening, sir. Dr. Dinesh Prasad. It was a nice presentation and very brief but very informative. So many endoluminal procedures you have described. There is hardly any comparison between different endoluminal procedures and endoluminal procedures versus lap niche and fundoplication. So without having direct head-on comparison, is it not difficult to define the absolute indications of these procedures, saying this procedure is better than that or that procedure is better than that? So without having the head-on comparisons, how can you reach that conclusion?
Yeah, so I haven't reached that because there is no head-on comparison. As I told you, the definite indications for the endoscopic is a small hiatus. If it is a large hiatus, definitely we don't touch it, number one. Number two, Mayo is doing now a randomized control trial comparing the esophagus, what FDA has approved, with a hybrid technique of laparoscopic hiatal hernia repair versus only esophagus. Probably that will give you evidence of the comparative study. But there is no trial till now done on an RCT or whatever it is comparing laparoscopic fundoplication with endoscopic fundoplication. And I don't think somebody will do it in future also, because if it is a large hiatus, obviously endoscopy has zero role in that. So I think with that, we don't have any comparison. We can't do any comparison.
Sir, do you think that lap niche is a very wide spectrum? It is fit for almost all cases of GERD with hiatus hernia?
Yes, of course. Yeah, yeah.
While all these procedures have very selective indications.
Yes, exactly.
If your selection is wrong, the procedure is going to result in disaster.
Yes.
It is going to fail.
Yeah. Same happens vice versa with the surgery also. As I told you, the meticulous workup. Because I see a lot of patients who got a laparoscopic fundoplication come back with persistent symptoms, or in fact, some people will have the dysphagia and all when you guys do the full thickness fundoplication.
That is the thing. One more thing on long-term follow-up. See, most of the procedures are there excellent on short term.
Yes.
But even if you do this mucosal resection, the short-term outcome is very good.
Yes, agree.
The data is quite favorable.
Yeah.
All the procedures, most of the procedures, rather,
Yes.
I can say.
Yes.
2-3 things matter. Long-term outcome.
Yes.
Most of the procedures, depending upon the time, they start failing with the time.
True.
PPI dependence keep on increasing year by year.
Yes.
And by 10 years, some have 30%, some have 20%, some have more than 50% PPI dependence. Again, the patient comes for the same situation. He is on chronic PPI. So does this long-term or time-dependent failure of the procedures, do you consider it to be a failure of the procedure or a partial success of the procedure? Because such patients do not require that high dose of PPI.
Correct, yeah.
When they do not require that much of their daily modifications.
Correct.
The symptom score has declined, but definitely they have to take the PPI.
So it's kind of people in that bracket come as on-demand PPIs. They might not require regularly, but it will be on demand, which is definitely beneficial for them. You know, the quality of life improve. That is the number one factor. And second, the PPI independence can be partial, if not complete. So at least those things will have definite positive outcome in a long run in these patients.
Some subset of patients with atypical symptoms, those patients who are having the what we call LPR or lower laryngopharyngeal reflux symptoms. We get such type of patients.
Yes.
They have, and particularly these are the patients whose diagnosis get delayed.
Yes.
They come very late, or accidentally they see some gastroenterologist or some surgeon doing upper GI-scopy. They find concomitant GERD or hiatus hernia, and they correlate this patient is actually the symptom of asthma or symptom of laryngeal irritation, chronic cough, and so many things. That is actually due to the GERD.
Yeah.
So their diagnosis is delayed. They are in the very late phase, and most of the time they have hiatus hernia.
Correct.
So what do you think? For such group of patients, which procedure is better?
Sir. Someone next is asking.
Yeah. So I'll conclude this. So as I told you, as of now, there is no role of any of these endotherapies or surgical therapies in a patient with LPR, number one. Number two, whether to diagnose it is LPR or GERD, as I told you, the armamentarium of those three tools are very important. Once you do a pH impedance 24 hours with a manometry and a good endoscopy, I think you can subcategorize into which category these people belong to, and accordingly you can take the decision.
Very excellent talk, sir. One very last brief question, sir. For a new beginner, for ARMA and ARMS, what is your take on tips or technical tips that to avoid complication, and what complication you have seen, sir?
ARMA, I think, fortunately, touchwood, no complications, zero. ARMS, as I told you, in a long term, we have seen a few fibrotic strictures happening. And of course, on the table sometimes bleed, if which can happen if you have any underlying vessels. And by and large, from past couple of years, we stopped doing ARMA and we are doing, arms, and ARMA is and as I told you, that's one important thing, take home message is difference between whether you have to do a ARMA or a GERD-X. Low volume reflex episodes, probably ARMA is better, but they have high volume reflex episodes, only GERD-X will do. Again, there's no data on that, but observation.
Thank you very much, sir. Excellent talk, sir.
Now you can start dinner, and simultaneously you can enjoy this entertainment program. Thank you.
Should. Okay.